Okay, guys, welcome to the October Lunch and Learn. Kelly Davis is going to be talking to us this time about blood flow restriction. So Kelly, take it away.
Awesome. Hey, everyone. Thanks for joining us today. So blood flow restriction training, what is it? It basically is, sorry, I keep getting these admit things. Basically, we look at reducing the blood oxygen levels to the muscles, right? And this type of training allows for low impact activities to produce high impact gains because we switch which type of muscle fibers are recruited. So we'll kind of deep dive into this and what the mechanisms are. Screen's frozen. Sorry, y'all. There we go. I want to start by talking about the history of where it came from and why it became a principle in the first place. So it was discovered by Yoshiaki Sato. And a practice that they do in Japan oftentimes is they'll do these prolonged sitting poses. And he noticed that just by the prolonged sitting, where you cut off some of the blood supply to the legs, it was actually creating these hypertrophic, basically hypertrophy within the muscles, which was pretty cool. So we looked at it more, and they started to develop these systems where they could replicate that without doing the prolonged sitting. So the very first one was called the Katsu unit, and it measured the level of occlusion within the limb, and then kind of studied some of the results. As it gained more popularity, especially in the US in 2010s, they came out with all these different devices, and we'll explore some of those later, but it became pretty mainstream in the 2010s. A lot of bodybuilders will use this, which is not our population. So we're going to look a little bit more into how we can help our population by using these principles. Basic principles of them. We want to diminish the arterial blood flow, so how much blood is getting down to the muscles, and occlude the venous return. So we basically reduce how much is coming in and kind of trap it there, okay? If we have less blood coming in, we have less oxygen available to the muscles because blood carries the oxygen in, okay? We have two types of muscles in our body. We have our aerobic and our anaerobic, okay? The aerobic are the type 1 muscle fibers. Those are your ones that require oxygen. They're going to be your slow twitch, your long endurance muscles. These are the ones where you're going to go for a long walk or run a marathon, right? Those muscles versus your anaerobic muscles, which are your quick power jumping muscles, okay, do not require much oxygen. The type 1 muscle fibers are not your muscles that are going to need that hypertrophy. So when you have a patient that is status post any sort of surgery, or they just have been deconditioned because they've been in a hospital bed for a long period of time, you're going to get the atrophy of those type 2 fibers or those anaerobic fibers. And that's what causes the atrophy. Okay, so if we can quickly fatigue out the ones that require oxygen because there's not as much oxygen available, it'll allow those type 2 muscles to kick on, even if we're doing these low impact activities. Okay, so it causes a disruption in the homeostasis of the muscle, and it forces the body into an anabolic state. Anabolic means building up. Okay, so it'll increase the amount of protein synthesis, which is what we want for muscular development. It'll improve the motor unit recruitment, and it'll increase the amount of human growth hormone that is available within the muscles, okay? All things that help us to build and create new muscle. Blood flow changes. So the arterial blood flow is allowed in at a slow rate, like we talked about. The venous blood flow is allowed out at a slow rate, okay? And it kind of traps it in there like a dam, okay? So at the level of occlusion, which is high up on the limb, it traps it in there. And it causes this distension. So you'll actually see when the patient is wearing blood flow restriction, you will see all the veins starting to pop out, okay, like the guy in the picture there, okay? They'll hit those fascial restrictions within the muscle, and the limb distends. It then creates what's called a muscle pump. So when you contract the muscles on these already distended veins, it basically pushes them together, and eventually it'll create enough force to push that blood flow over the level of occlusion, okay, or the venous blockade, and it allows more blood flow in as we're doing the rest period. And we'll go over the parameters in a little bit. So basically it holds all the blood in, you do the contraction, it push, and eventually it'll knock it over the occlusion Okay, and then it allows it back in. I want to talk about some of the other changes, the positive changes that you can get from blood flow restriction training when done properly. We talked about human growth hormone having an increased level in the body after this. That basically will reduce the amount of fat and it will increase the amount of protein. So both things that we want to do for regular training, much less for any of our patients, especially deconditioned ones. Okay, we also have neural changes where it'll increase their heart rate, increase their sweating, and increase their ventilation. My patients all the time, literally when they're doing, they're like, I don't understand how I can't breathe. And they're like, I'm doing the most basic things. But because of the way the body is responding to the blood flow restriction training, you'll notice all of these changes. Okay, so does it work? Let's look a little bit about the research. Literature review that I found, and it was referenced in all the literature reviews that I found. Basically, it looks at 3 different training conditions compared to each other. Low intensity, so normal, what you would do for those aerobic muscles. Low intensity with occlusion, so the blood flow restriction, and then high intensity, which is going to be your heavy plyometrics, your sprinting, okay, your short things that are low reps. It's an 8-week training program, and blood flow restriction was used, or each of the parameters was 3 times a week, regardless of which group you were in. Okay. Studies showed that the peak torque value, so how much torque the muscle has, were similar between the high intensity and the low intensity occlusion. Sorry, I can't speak today. So basically, doing your jumping and plyo and really high level intensity things had the same torque values or very similar to doing low intensity exercises, but with the blood flow restriction. So you can see it's 22% for high intensity and 18% for low intensity with occlusion, but only 1% for that low intensity. So those are pretty significant. In adolescents, so anyone under the age of 21, I think was the criteria that they put for that. The low intensity with occlusion was actually more effective than the high intensity. So any of your athletes with ACL, things like that, this is huge for. I use it on my ACL athletes all the time because you know they have so much atrophy early on. And normally it'll take me like 7 months to get their quads looking even remotely normal. If I regularly use the blood flow restriction training, it's like 2 to 3 months. It's a crazy difference, or how much stronger they are in that period of time, because we can do low level things, but get those high muscle gains. This is just a graph that's showing that. We have A up here, the high intensity, and you can see the post-training versus the pre-training, and all the numbers went up, right? Low intensity with occlusion, all of them as you increase the velocity, right? They're all it's gonna trend down. You can see all 4, but all of them had similar gains between the high intensity in A and the low intensity in B. They look pretty similar, okay, with how much gain you got between the white and the black dots versus the low intensity without occlusion and the untrained group. You can see how there's little to no gain there. We talked about cross-sectional area, how it hypertrophies the muscle, okay? So it showed that there's a higher cross-sectional area of the target muscle group, okay, but also a higher cross-sectional area of surrounding muscles. So not only are you working, if you're doing a squat, right, you're not just gonna be working the quad, it will also fire in the glutes on the lateral aspect and your actual glute max. They found changes in your hamstring. So all the muscles that are around it, both proximal and distal, notice that they had both hypertrophy and hyperplasia. So it got bigger and there were more muscle fibers. Okay. They also looked at EMG activity. And this, again, kind of like we just said, increased actual neural activity with the target, the proximal, and the distal muscles. And it stayed high through all sets. It didn't diminish like you would normally expect to see in a low intensity activity. It showed that the myelination of the nerves increased, that bone mineral density increased, which is huge for our populations with osteoporosis. And it showed angiogenic changes. So blood vessel strength improved and it adapts better to pressure changes. So people with high blood pressure, this is shown to help increase the strength of those blood vessels to allow for those pressure changes. I was going to say for the bone mineral density, the studies that I saw on osteoporosis in particular showed that even just walking 20 minutes a day with the blood flow restriction training significantly increased their bone mineral density when they rescanned, which I thought was pretty cool. There are many different types of BFR cuffs out there now. Like we talked about in the beginning, it started with that Katsu. And then the next big one that kind of came out and was the gold standard for a long time was the Delphi unit, which is listed at the bottom there. It's like a $5,000 machine. It basically, you lay down, it checks your limb occlusion pressure. So how much force does it take to fully occlude the limb? And then it'll back it off to a percentage. But then you're tethered to that machine. Like it constantly is checking it so that it makes sure that your limb occlusion is at the same rate, but you are stuck. So the machine moves with you and it's very limiting in what you can do. The newest ones to come out that I've seen are smart cuffs and air bands. Not a lot of great evidence or research on them that I could find. I know people use them, but I don't have the research to back it. There are straight occlusion cuffs, which are terrible, but that's what a lot of the bodybuilders will use. And they're just these basic straps that you can like pull and tighten to a certain number. Edge cuffs are another one that are similar, but they're a little more flexible than the occlusion cuffs. And then there's B Strong bands, which are the ones I have the most experience with as I went through all of my training on BFR. They're the best, and we'll kind of talk about their principles and why they're better than some of the other ones. But it's the one we'll focus on today because it's easier for us to standardize if we all kind of use the same one. So things to consider when we talk about blood flow restriction training. Do you need to find the limb occlusion pressure? So if you look at the studies, right, and I just talked about how you occlude the limb fully, kind of like if you are taking somebody's blood pressure, right, you pump it up until the limb is totally occluded and then you slowly let it down and see when the heartbeat comes back. So they want to figure out what pressure fully occludes the person's limb. And then typically they'll take a percentage of that in order to make sure you're training at the right velocity. With certain units, this is very important. Luckily with the B Strong bands, you do not have to, because no matter how much you inflate them, even to 500, because of the way they're designed, you're never going to fully occlude the limb. Okay, but the research shows that you don't have to measure the limb. Sorry, I keep getting admit things. You don't have to measure it for it to be effective. Does it require you to be tethered to the unit? I think as physical therapists, this is a big thing for us because we don't want them to be tethered to the unit. Sometimes it's crazy. We want them to be mobile, and we don't want them to be limited in what they can do by being stuck tied to a machine. The width of the cuff. So the reason the B Strong bands never fully occlude is because they're quite narrow and they have these kind of cylindrical chambers that fill. Versus if you look again at a blood flow cuff, a blood pressure cuff, they're very wide, okay, and that width is what will occlude it versus the narrow band. So when you're looking, if you choose not to use B Strong bands or you use other methods, look at the width of the cuff. Pneumatic or static. So pneumatic means it's flexible and it has different chambers that can fill versus static, one chamber that fills all the way around, or those bands that I talked about that are very rigid and you just kind of pull them to a number where it feels like the limb is occluded, they say to a certain percent. Okay. And also flexibility. Okay, similar where it's, pneumatic was can you inflate it or can you not inflate it, versus flexibility, is it rigid versus does it have subgive to it? Okay. Perfect. So here are the B Strong bands. Okay, they come in 5 different colors, and the colors are simply the width of the band or the circumference of the band when it's on. For most people, the blue band is great for the legs and the red band is great for the arm. You're going to have some bigger patients or athletes where you may need to go up to a yellow. Gray, I've never used on a single patient ever. And sometimes you have teeny tiny baby arms and the green works really well, or you've got like a young athlete or, someone who's like 12. But typically if you're going to get 2 colors to start, the blue and the red are a pretty good investment. They have small cylindrical chambers like we talked about, and they inflate, they partially occlude the limb, they never fully include. So they'll do they did Doppler studies at the arteries in the feet as they fully occluded to 500, and it showed that there was still a distal pulse, which is good because you don't want to fully occlude the limb. Okay. It is pneumatic, right? So you can control the pressure. It basically has this little plug, and I can grab one in a second. I meant to bring it in here, I'm sorry. And you plug it in and you inflate it just like you would a blood pressure cuff, and you see the little dial going up. We will talk about the parameters in a minute, but it is very easy to like just pop it on and see what the pressure is, and you can inflate or deflate as needed. It is elastic, right? You don't want tourniquets and you don't want those thick, rigid straps. It has the narrow band that we talked about, and it's untethered. It does not, Lauren brought them for me, thank you. It is untethered, so you can be mobile throughout, okay? So each band, because it has a different circumference, has a different starting pressure. And Starla posted the parameters for this through Datto, so we can go over the protocol in specificity if we need to. But like I said, red and blue are typically going to be the sizes that fit most people. When you start with, and there's always, it does come with a little card in the kit that has the same thing, so it's very easy to reference. So you always start them at that initial pressure, and then we'll go through our first set, okay? Once we get through the first set of 30, okay, we say, did you have fatigue to the level we wanted? If you did not, right, we'll increase it a little bit for the next set. If you had way too much fatigue, then we need to decrease it. Okay, I think the next slide. Okay, we'll do dosing in a second. So length of wear is important. You can wear it continuously for 20 minutes per limb. So you can either do both limbs at the same time if you're only targeting one leg because it's an ACL or something where they have just atrophy in one limb. It's just 20 minutes per limb, and you do not need to deflate it while they're resting. You can do it up to 3 times a day. I have never had anybody do it 3 times a day because they're usually pretty wiped after, but studies show that that is acceptable. And most studies show that they use this as an adjunct to their training 3 times per week. Okay, so like we said, there's the initial set of 30 reps to test. Once you get into that 30 reps, I usually will tell my patients on a scale of 0 to 10, 0 is no fatigue at all, and 10 is like, I could barely complete that set of 30. I ask them where they are. I want them to be at about a 5 or a 6. Like it should be challenging and they should notice some changes, but they're like, I could totally do a second set. Okay. And then it says they're mild fatigue only on the last set. That's as we go. By the second set, you should have them at a 6, 7, maybe pushing an 8. And by the third set, they should be like, oh gosh, that was really hard to complete. Okay. There are 2 different parameters. You can either do 3 sets of 30, or you can do 30, 15, 15, 15. So an initial 30 and then 3 sets of 15. After that first set, you inflate or deflate according to the patient response. And they do recommend that you adapt the pressure before you increase the resistance. So if they're doing, some sort of pull down, right, where it's on a PRE or a cable column, right, and they didn't have any fatigue, try increasing the pressure before adding weight to it. But the dosing does vary, and that's why I said you can either do the 30, 30, 30 or the 30 with 3 15s. This is what we just talked about. The rule of thumb is they get 30 seconds of rest between sets, and I usually will time it, and they get a full minute between exercises. Some of our patients, especially if they're super deconditioned, need a little bit longer rest, but the studies show that this is the optimal rest time between each of these sets, whether you do the 3 30s or the 30 and 3 15s. Safety, I'm going to pause for a second here and I'll show you guys what our blood flow restriction bands look like. Ooh, so here they are. I don't know how to unblur on this, Sarla, sorry. But here they are. So this is the blue tab one, okay? And it's got this nice cleanable surface on the inside and then a Velcro surface on the other side. I don't know how to blur, I'm so sorry. And then it has this little nipple, which is where you attach the cuff to, okay? So they all come with an inflator pump and it just has a little nozzle at the end, okay? All you do when you put it on. You know what? I'm so sorry, guys. Let me figure out how to unblur so I can show you. Oh, I figured it out. That was easier than I thought. Okay. When you put it on, I'm going to do it on a leg. Okay. The principles are the nipple part, okay, goes towards the body. Okay. So if it's going like this, it should go in. Okay. You want it as high up in the groin as possible as they can tolerate. Okay. Put the tab through here. Okay. And then you pull it so it's snug. It doesn't have to be super tight. I do not know why the nipple has to go towards the body, but that is always the way they've taught us. So that's the way that I've always taught everyone. Okay. On the little tab here, right, there's a little silver button. You have to make sure that's pressed in, and then you just push it right onto the cuff. Okay. And it snaps in. From here, you want to make sure that the gauge is closed and you just squeeze like a normal cuff. Also make sure their weight is equally distributed between their feet and they're not standing in a funny posture. And you increase it. I'll go to 250 since that's the blue recommendation. Okay, so you check there and you can just simply detach by the silver button. Okay, and then they're untethered and ready to go. Okay, but it sits pretty high up, right? You want to occlude it as high as possible. Okay, when you deflate, never deflate using the pump. It'll break the pump. There's a little release button. So you just kind of, I'm gonna move my hands so you can see. Okay, so you just kind of squeeze these two together and the pressure will release. Okay, so it's super easy setup. You can always check their distal pulse to make sure that they still have one. But it should be pretty easy to set up. Okay, and we can go through a question about that later. So safety, who is it safe for? There are certain contraindications, people you cannot use it for, people with sickle cell anemia, just because of the incidence of DVTs. But again, blood flow restriction for the B strong bands does not occlude, so there's no tissue damage, but it's better to just avoid it if at all costs, right? Any untreated DVTs, so technically it's a precaution if they have a history of DVTs, but you can still do it because it does not fully occlude the limb. If it's an untreated DVT, they just have one sitting in there and they're not doing anything about it, that is a contraindication. Untreated hypertension. So making sure that you are screening your patients for super high blood pressure. If they are on medication for it and it is maintaining it to a reasonable level, like that you would feel comfortable anybody exercising with, that's fine. Nothing for pregnancy. If they have a fever or an active infection, you don't want to do it. Lymphedema, for obvious reasons. You don't want to compress the lymph system even more than it already is being compressed. Any open wounds or around IV access points. Okay, most of those are pretty straightforward. There are built-in safety features with the B strong band, which is why I like them. Again, never fully occludes the artery. It allows for full range of motion of the joint. A lot of them will kind of block because they're either too thick or because they're too restrictive. You can always monitor exertion and pain levels with the patient during, and it's very safe for post-operative use. Use it isometrically. There have been good gains, and you also get systemic carryover effects on the non-surgical limb. So if you do it on, if they're non-weight bearing and you do it on their non-involved limb, there will be systemic carryover, which I think is pretty cool too. I saw it used on this US ski, a member from the US ski team, and he had fractured his femur and they got him back like in a ridiculous, because it again helps increase bone mineral density. So his healing time for his fracture was crazy, and they actually got him back in a stupid amount of time. I don't have the exact numbers on it, I'm sorry, but it was actually really cool to watch because they filmed the whole thing and did all the studies on him. That is everything that I have, and I feel like I went through it pretty quickly, so we can go back to whatever we need to, if anybody has any questions.
I have a question. How much are the B strong bands? Where can you get them?
So you can get them, currently you can get them on Performance Health, but I know we're getting rid of Performance Health soon. I got them directly from the Be Strong website. It's a TheraBand based brand, and they always do 10% off your first order. I want to say the set, like there's 2 of these in my one little case, plus the pump is like $295 or something like that. So you can get them pretty easily, and for, under 500. And they also sell sets. They'll sell the whole kit, but I think $295.
Cool. Looks like Sharon has her hand raised. Go ahead, Sharon.
On behalf of the Sacramento Clinic, we are raising a hand for a question. You talked about the femur fracture. At what point during the healing is it okay to introduce BFR training?
You know what? That's a great question that I don't have an answer to, because I've never done it on somebody that's, usually by the time I get them, these were athletic trainers that were using it. By the time I get them or we get them in our setting, they're like, okay, 4 weeks out, where it would be safe to start loading, according to whatever the doctor restrictions are. But again, if you're going to get that crossover gains, and you can do whatever you need them to do single leg and get some of those bone mineral density gains, I think that's awesome. So I don't have a great answer for that. I will try to find that study, but
we have a comment in the chat. Russ says he's done them 1 to 2 weeks post-op. Oh.
Yeah, I do them literally 3 days post-op. You can start them really early. And like I said, I'll put them on both sides and I'll do isometrics on one or whatever, is safe and functional at that point. And then I'll train them heavy on their other side and get the crossovers. It's literally, it cuts like 4 to 5 months off of my, making their limb look normal and all of their strength gains. To the point where we have an ortho surgeon here who literally he's like, you're getting my ACLs because you have BFR and you use it well. You get good results with it.
We do have, I apologize, I don't know who this is. Whoever's computer is clinician raising their hand, and they have something in the chat. Do you see many osteoporosis patients? You can unmute and ask if you have a more specific question as well.
It looks like not unmuting. So yeah, we do see, I'm out in the desert, so I have a lot of older population, and a lot of them have osteoporosis or osteopenia. And like I said, the studies will show that even just walking for 20 minutes a day with the blood flow restriction on, you don't even have to measure fatigue levels. You just put it onto the recommended pressure and walk for 20 minutes a day. Their bone density went up to the point where I had a patient who had been on medication for years for osteoporosis, and it actually went up on the standard deviation scale to where she was closer to osteopenia, which is pretty cool. There are certain types of autoimmune osteoporosis where it won't work as effectively because your body's constantly catabolically trying to break it down, of whatever that autoimmune one is that I can't think of at the moment. But I mean, for the most part, absolutely. I see a lot of them and it's very effective.
Awesome. I have one other question too about safety. I saw some stuff about exercise-induced rhabdomyolysis. Are you familiar with that or aware of what might cause that?
So exercise-induced rhabdo in general is basically overtraining. So you need to really monitor your patients for any signs of rhabdo. I can't think of them off the top of my head, so great questions.
Not to put you on the spot.
These are low level exercises. You can do high level stuff with them by all means. And I have done, when we were going through the training, we did crazy jumping and whatever it may be, but these are literally heel raises, body squats. They're not things that would cause rhabdomyolysis, and the blood flow restriction itself does not. There were 0, I think the research said there were 0 cases of exercise-induced rhabdo when it was looking at the blood flow restriction training with the Be Strong bands. I can't speak for the other ones because I was more focusing on these, but yeah, it allows you to do these low intensity exercises, which are not likely to cause overworking or rhabdo.
Right, that makes sense.
Hey, we have a quick question.
Yeah.
Have you seen any studies or any personal experience with using it for rotator cuff intervention versus distal upper extremity? So in other words, if we're trying to occlude and contract a muscle, work it on an oxygen deprived state, it totally makes sense for lower extremity, Achilles, quad, etc. If we're using it for rotator cuff and we're getting more of a venous or a circulatory pooling, or, you know, what I mean, it's occluding it below the level versus above the level. Has any research shown that it makes sense or it's effective for rotator cuff?
Yes, so it's a two answer to your question. So yes, because all the research shows that whether it's upper extremity or lower extremity, it affects the target muscles, the proximal and the distal muscles. So you will definitely get gains for the muscles that are proximal to that, which includes the rotator cuff, right? But your rotator cuff by nature are more of those endurance aerobic muscles, so they're going to actually fatigue out quickly. And part of the reason for that is they're small muscles that run in small spaces, and we don't need them to bulk. We need them to last for longer. And this is looking more at hypertrophy gains, and we don't necessarily want them to have hypertrophy. So you will get increased EMG activity up there. They are working and firing, but it's not a muscle. Their muscle makeup is going to fatigue out, and it's not going to be the target fiber type, essentially. Does that make sense? Good question, though.
Was it contraindicated for diabetic patients?
No.
Okay.
Even with neuropathy, it's safe because it doesn't occlude. It never occludes the nerve. You have full neural function.
Hey, one more question, and we can ask offline. We actually were looking at doing a study with one of the department chairs up here in Southern California on the use of BFR with patients diagnosed with moderate knee OA. For the treatment of knee OA, did you see anything in the research? Have you read anything about potentially why it would help knee OA? Because we started seeing, we use the Delphi unit here, some pretty good results after 15 or 20 years of not using BFR. All of a sudden, we've been using it for several years, and we're like, there's something to this.
Yeah, you're like, it actually works, right?
Yeah, and it's obviously quad hypertrophy and lower chain strength is one reason, but there's something chemically or something along histologically, I don't know what Starlin knows the right word, histologically or physiologically effective with BFR with arthritis. Have you seen anything with that in the research, lactate production or anything like that?
A lot of it is this HGH because it increases your human growth hormone, right? And remember, it sends your body into this anabolic response, which by nature builds, right? So let me go up a couple more, right? So it's going to increase the protein synthesis. So we know that from a muscular standpoint, right? And it increases the human growth hormone. Where's the one that I want that says the density? This one. Yeah. Okay. So the human growth hormone, where it's going to reduce the amount of fat, right? But increase the amount of muscle, right? So you've got that bulking point part, right? And it sends it into this anabolic state. So you're getting better bone mineral density, right? You're getting this healing factors that are going in. All of the changes combined that are allowing your muscles to fire better and offload the knee, but also increasing the amount of healing properties. Kind of like, I don't want to relate it to PRP, but you know how PRP is anabolic in the state that it like increases the amount of healing factor that is within the knee. It's kind of a similar principle. So I haven't seen any particular studies that isolate knee OA, but if you look at all the individual principles of BFR and how it helps to create an anabolic environment, it makes sense that it would have some healing properties there.
Good questions, guys. Anything else?
Sacramento has one more.
Go Sacramento.
We had a question about endurance training. Like, would you incorporate this into like endurance training if it was maybe a marathon runner? How does this play into their training or treatment?
Well, that's an interesting question too. So this is an adjunct, right? You're still going to train people up to their specific sport or what their muscle type needs to be, right? But marathon runners in general, you know, they're very catabolic, right? The longer you run, you get that breakdown. That's why they're thin. They don't have those bulky muscles. Okay, but they need more of those aerobic muscles to perform their sport. But if we're looking at it from a sense of, hey, you need some balance and you need power and you need XYZ, it's great to throw this on as an adjunct for those more endurance athletes.
Thanks.
Yes.
How young is too young?
How young, you know what? I don't have a good I don't have a good answer for that, but I've used it on 8-year-olds, but that's the youngest that I've ever treated. And they love it. They have fun. I kind of just let them run around and jump with it and have fun. But if they like, especially after if they've been casted or braced for a long period of time, I think that one was a patellar fracture, something like that, like a traumatic fracture. And she had to be locked in extension for 6 weeks and just all went away. So as we started getting back into weight bearing stuff, and it worked, it was effective. And the studies did show that it actually works better than high intensity training for adolescents. So, but I do not have a young, but I don't see less than 8 and I used it.
Any last minute questions before we wrap it up? All right, guys. Well, thank you for your attention and your time on your lunch break. So like usual, I will post this to the YouTube channel if any of your colleagues missed it and wanted to watch it. This is actually going to be our last Lunch and Learn of 2022. We're going to take a break in November and December through the holiday season and the craziness of that. And then we'll pick back up in January. Thank you
Thanks
so much.
everyone.
Have a good day, guys.
Bye.